LV global longitudinal strain. First of all, first question is what is the need for LV global longitudinal strain? This is the evolution of echocardiography by MO, 2D, pulse Doppler, continuous wave Doppler, color wave Doppler, TEE, stress echo, contrast, all these things. We can tell ejection fraction, we can tell about the mean gradient, peak gradient, and left to right shunt, and some regional wall motion abnormality. What is the need for strain? And when a healthy individual is bombarded with risk factors like diabetes, hypertension, dyslipidemia, alcohol, smoking, obesity, either as a single parameter or in combination, they trigger neuroendocrinal activation and its sequelae, simultaneously microvascular inflammation and its sequelae. This leads to cellular, molecular, metabolic and structural changes in the heart. This stage, up to this stage, we call it as stage A heart failure. Up to this stage, we call it as stage B, that is called the pre-heart failure. And subsequently, after a period of 5 to 8 hours, 8 years approximately, from stage B to stage C, you develop fall in ejection fraction. That is the stage we patients say with symptomatic heart failure. This 5 to 8 years lapse can be identified by myocardial strain, myocardial imaging. This we do it, in this stage we get all these things in hemodynamic image. This, when you know the myocardial imaging, we can identify the pre-heart failure that is approximately 5 to 8 years ahead of the hemodynamic fall in ejection fraction. And what is the basic of this 2D strain is speckle tracking echo. This is speckle. The basic unit of any image is called as pixel. That 30 to 40 pixels unite together to form a kernel. 40 to 60 kernels fuse or conglomerate to form a bright spot that is called a speckle. These speckles can be tracked and it can be tracked through the cardiac cycle, and where you get this speckle tracking imaging, and this can be tracked through the, this can be tagged as well as tracked. That is the idea behind this, tagging and tracking. And when an object is moving without change in the shape, we call it as displacement or translation. When it moves along with alteration in shape, we call it as displacement with deformation. The local tissue deformation is called strain. The rate at which strain occurs is called strain rate. And advantage of speckle tracking echo or 2D strain is no angle dependency, no noise interference, minimally affected by intra and inter-observer variability, not affected by cardiac translational movement, highly reproducible. Other mechanics like radial, circumferential, torsion, rotation, etc., apart from longitudinal shortening, can be obtained. Myocardial strain derived in ST is well validated by sonomicrometry method and tagged MRI method. This is a proven method. And how to perform 2D strain imaging? The basic and fundamental of 2D imaging is you should have a very good quality 2D imaging with the entire myocardium should be visualized, very clear-cut endocardial margin. ECG gating should be always be there. Frame rate should be 40 to 90. If the frame rates are extreme, you may not track the speckles and you may lose the speckle tracking. Irregular rhythm should be avoided. Artifacts, movement and respiratory artifacts should be overcome. Ensure adequate tracking and ROI, region of interest placement. We will see what are all the problems in day-to-day practice. And this is how we proceed with conventional AFI method. You acquire raw data with 3-chamber view with very good endocardial border delineation and place the region of interest in the myocardial and the mitral annulus junction in the endocardial border. The machine automatically, the newer machines will automatically tell where to put the ROI. The older machines we have to put. And next, the tracking, the tracking is happening, and the parametric image is the last first step. And machine will automatically divide, the software will divide the entire this point of 3-chamber view myocardium into 6 segments and gives the marks according to the shortening of the images. And it gives you in the waveform as well as in the curved M-mode form. The third thing is the apical 4-chamber view, same method, where to put the ROI and how to proceed with the acquiring images, and 2-chamber view. And finally, it will give the waveform. From the waveform, we can say whether that segment is lagging behind, it is hypokinetic or not. There is dysynchronous contraction in various segments or not. It will give you in the waveform. Final is the bullseye format. All the 17 segments marks will be there in the minus form, and normally it is more than 18, minus more than 18%. From this number, from this segment, we can get so many informations regarding various heart diseases. And before we go into the clinical utilization, what are all the drawbacks we come across when you go through the speckle tracking imaging? The foremost and first is foreshortening of the image. In the process of getting good image, one will be inadvertently go to one space above so that you will get a good image, but at the expense of foreshortening. The effect of foreshortening, how to identify, is normal left ventricle is prolate ellipse, whereas the foreshortening will be little bit ovoid in shape. And the apex will be thickened. These are all the clues to identify foreshortening. What is the effect of foreshortening on 2D image? That is 2D strain imaging. Foreshortening will increase the absolute value of GLS, will increase falsely the ejection fraction, and apical thickening will be there. Coming to the other practical points, papillary muscles should be avoided and trabeculation should be avoided. The exact compact layer should be measured. Trabeculation should be avoided. And coming to the other practical points, 2 low points in the intraatrial septum and the lateral atrial border will underestimate the imaging. And again, it should not go beyond the LVOT and the junction. Here you are going in the LVOT area. Again, too wide the ROI width, if it is too wide, it will incorporate the pericardium so that it will give you underestimate the GLS values. And if you focus only on the endocardial border, you will get falsely high GLS values. These are all the practical problems you should overcome while doing AFI imaging. Coming to the respiratory artifact, the apical 4-chamber view, septum is not the lateral wall. You should patiently wait for the end expirate.
Can I just interrupt you? Very good. Are you looking at the subendocardial strain, myocardial strain, or epicardial strain?
It is because longitudinal fibers are situated in the subendocardium. Yeah. Primarily, so we are looking at the
subendocardial strain. So that's just make sure the point.
Exactly, because major portion of the longitudinal fibers are situated subendocardially. We are bothered about the subendocardium.
So this is the subendocardial. So when you are getting the total global longitudinal strain, how is it calculated?
It gives you approximately 1/3 of the ejection fraction. 2/3 are decided by the...
No. What I'm saying is, because it's a basic session, so we're just interrupting. What it does, you look at you're looking at the peak strain in different segments. For example, if you're looking at the septum, you're looking at the peak GLS strain in different segments, and then you're averaging it. So what you're getting is average, peak. So we are
global average strain.
Global longitudinal strain.
Global average strain.
Yeah, that's just to make sure.
All the segments are averaged, so and you give that mark.
Yeah, you get the peak from each segment and then you average it. So it's a peak, average, global strain.
That's peak. Exactly. Thanks. Respiratory artifact. This is the lateral wall is not visualized. We have to patiently wait for the end expiratory phase. Then only you should grab the same image. Will be better delineated. If you ignore this artifact and you do this, these areas are contracting, this area is not at all contracting. That means this is not sensing, that RO is not tracking. So this is after doing proper scanning and you do the things, repeat the same thing, that will be contracting. if you overdo the things and machine is unable to track the images, it will say I am unable to accept the tracking. It will put to X mark or into mark in some of the segments. If the segment, if you get X marks in more than 3 segments, that means you have to ignore this image. You have to acquire a fresh image and you should go again.
One other question, basic, is that how does this differ from MAPC, or on the right side from TAPC? So you're looking at the mitral annulus motion by M mode, and on the right ventricle you look at the the tricuspid annulus motion. So how is the strain different from TAPC or MC?
That is
Just
angle
look for
dependent. That's the TAPC and MAPC are angle dependent.
Yeah.
This is not angle dependent. Moreover, this tells you only that particular portion of that segment is analyzed. Here, the overall performance is analyzed.
Yeah.
That
So when you are looking at TAPC or MC, you are looking at the motion of the annulus going towards the apex. Only the motion of the annulus. When you're going for strain, you are looking at the motion of all the segments of the wall going towards the apex. The apex doesn't move much. It's the base which moves towards the apex. The apex doesn't come down that much. It's the base which goes up to the apex. And also, if you can explain why it is called minus, you come later on that.
Pardon, sir?
Why is it called minus 20 degrees? Or?
From diastole to distally, we are measuring. So we from initially a larger length, it shortens during systole. That is why it is mentioned as minus. When you go for diastolic event, if it occurs, then it will be expressed in plus only. The radial strain, except one thing is, radial strain will be expressed because from smaller volume it increases in thickness. Radial strain will be in the positive manner. The rest of the strains will be expressed in minus format.
So the minus simply is not really an algebraic minus. It simply means it's plotted below the baseline, because when the base moves to the apex, the length will become smaller. So therefore it's called minus. So minus 20% is better than minus 10%.
Minus.
I just want to, basic, So
Thank you, sir. So machine will tell you that I am unable to track. You have to get a fresh image and you should not meddle with these images at all. Finally, the technical point is sometimes you may get a positive, that is, instead of systolic contraction, there will be lengthening, shortening. These segments are shortening. Isolated segment of lengthening may be present when you do incorrectly. That means if it occurs in the apical area in the context of coronary artery disease, we can say this is left ventricular aneurysm, like that. When a single segment says unphysiological value, you should be very cautious. You repeat the imaging, the same patient, I repeated the imaging, then it shortens. That means these are all some of the practical points. When there is unphysiological value in one single segment, you should not give credence to that value. You have to repeat the image and reshape. And what are all the advantages of AFI imaging? This is less operator dependent, repeat test variability, less test repeaters variability, less influenced by loading conditions and heart rate. Advantages in sequential follow-up. This is more important. Cardiotoxic drug therapy, decision making before ICD placement, valvular heart diseases like the Tandon has pointed out, serial fall in the GLS, that tells you that is an indication for an early valve surgeries. And sensitive and robust marker for detecting subclinical LV. This is where it stands. This identifies subclinical LV dysfunction before the LV ejection fraction falls. Well validated. AFI is myocardial imaging, whereas EF is volumetric imaging. Some of the clinical applications we will go ahead, and this is the bullseye parameter. When looking at the colors, looking at the numbers, we can tell you something approximately. The bright red denotes this normally contracting segment. Pale red or rose color that means something when going wrong. That minus 4, minus 4.5, less than minus 4, minus 3, minus 2, like that. If the segment tells you that number, that means that area is akinetic. In between, we can say these are all ischemic.
Showing the middle as the apex.
Pardon, sir?
The center is the apex, you know.
Yes, sir.
So, I mean, you need to show them, no?
Exactly.
Center is the apex, and then on the top
This is
so,
the apex, this is the mid area, this is the basal areas.
right. So you're
This-
taking the ventricle and squashing it. So the apex comes in the center.
Center. And apart from this gives you global segment. Looking at this bullseye, I can say this is a normal segment, this is an infarct segment, this is a dyskinetic segment. And apart from that, global longitudinal strain, also it gives you overall ventricular performance. And looking apart from that, the area in which it occurs, we can tell you this is the LAD territory area, this is an LCX territory area, this is an RCA territory area. Looking at this bullseye alone, we can tell you something about the ischemic severity and global function as well as territory of the artery also we can tell you. Coming to the other utility, this is the most useful thing. This is before starting anthracycline therapy in a cancer patient. This is the baseline therapy, the baseline echo. Ejection fraction is 78. Nowadays, we don't do this Tichol's method because of the 2015 guidelines. And the automatic endocardial border technique, this is 64%. And look at the basal GLS, that is 20 minus 21.8. This is before starting chemotherapy. Exactly 3 weeks after that anthracycline therapy, ejection fraction is 78, did not change. The EF 64 to 68, no significant change in the EF, but global longitudinal strain has dropped from 21.8 to 17.6. That means there is a clear-cut drop in global longitudinal value. That is 4.2 is the absolute value. 19.2% is the relative drop in. How do you calculate relative? 21.8 has dropped to 4.2. How about 100%? 100, if it is 100, this will be the 19.2 will be the relative drop of GLS. This relative drop, what are you going to do with the relative drop of GLS? If it is less than 8, that means there is no subclinical LV dysfunction. This patient can go ahead with the next dose of chemotherapy. If it is more than 15, in this case 19.2, then previously we have to stop the chemo and restart with the lower dose. Nowadays, they continue the chemo with the cardioprotective agents. That is the significance of relative drop in GLS. This will dictate the subclinical identification of the subclinical LV dysfunction.
Does your oncologist believe you?
Yes, sir. Certainly.
Anyone has experience with this, with the oncologists? Well, most of the oncologists, some of them have started to believe, but most of them don't believe because they can't see, that there is a change in the function. They just look at the number, right? The numbers has gone down, but there is no way for them to know whether it's, whether the motion has decreased or not. So that is the big problem with the GLS. Well, ejection fraction you can show them, no? You can see the ejection fraction is normal, and now the ejection fraction, the walls are not coming in together. So that's easy for us to make the oncologists believe that there is a change. But when you are looking at the global longitudinal strain, you really can't tell the difference. How much the base is moving towards the apex. Not very easy to see because the change is only 15 to 20%, very little, very little change. So that's more difficult for the oncologist to believe. So most of us have a hard time in making the oncologists to believe to change their therapy based only on the strain. So they would also like to look at ejection fraction. Just an idea. Sorry to interrupt you, but I wanted to make sure.
So this is the key role in cardio-oncology. This GLS relative drop plays a crucial role. Next step is hypertensive heart disease. Ejection fraction is normal, but there is subclinical LV dysfunction. Coming to the diabetic heart, ejection fraction is normal. Global longitudinal strain is minus 15.1. If there is progressive drop in GLS in this patient, when we don't look at this progressive drop in GLS, when you look at the ejection fraction in this diabetic patient will be receiving insulin and OHS. But when there is clear-cut drop in GLS, this may go in for this patient going for diabetic cardiomyopathy. This is the ideal time to start beta blockers and ACE or ARBs like that. So this plays a crucial role in diabetic patients especially. And coming to the valvular heart disease, Ejection fraction is 74, severe aortic stenosis, global longitudinal strain is less than 15. If the global longitudinal strain is less than 15, this will tell you about the survival of the post-operative survival will be very minimal if you submit this patient. The same holds good for mitral regurgitation and aortic regurgitation. Just now Tanton told you that is matter of 18, less than 18 is the cutoff for submitting the patient for surgery. Lastly, the global longitudinal strain plays an important role as a prognosticator apart from ejection fraction. And thank you very much for patient hearing.